Good morning, everybody. Welcome to class. Today we're going to be covering a chapter on related disorders, autism, and attention deficit disorder. So let's get started. First slide. If I can make this move. There we go. There we go. All right, warming up here. Okay, so first of all, just covering a few of the things that we've been talking about every time we're together. Your practicum paper is due this Friday. You do need to post over the weekend on the counter article. On Monday, next week, we will have our final quiz. It's going to cover co-teaching, collaboration, learning theory, instructional practices, what we're covering today, related disabilities, and then that counter article. We're going to go through Chapter 9 next week. Chapter 8, actually, and Chapter 9 are our last two chapters on young children with learning disabilities and adolescents and adults with learning disabilities. Don't forget the study guide is out on Moodle. And next week on Wednesday, I'm planning to have a little time in class also to do some review, and then Friday will be that optional review day. And we can talk some more about if we need something in the evening for anybody that wants it. And then also don't forget, on the 9th, your article summary paper is due. You can pick any of the articles that we've been going through in class and write a brief summary of it. Okay, so as I mentioned, we're going through this chapter today. So the first topic we're going to hit on, I'm going to move myself because I'm right on top of that. We're going to talk about autism. You kind of have to almost be living under a rock to not know about autism spectrum disorders. April is Autism Awareness Month. That just ended. One of the things that coincided or came at the very conclusion of this month was the Center for Disease Control presented a brand new prevalence rate for children with disabilities on the autism spectrum. And you can see the chart here on the slide. It shows that now 1 in 59 children will be identified on the autism spectrum. That is a huge increase from 2 years ago. 2 years ago it was 1 in 68, and you can see the little box right up above me that says the new estimate represents a 15% increase. And just looking at the chart alone gives you that sense of, wow, where have we gone from 2004 to 2018? Some people would say, well, it's, we're out of control. There's something going on. It's, it's a chemical base. It's, some people believe the old, totally misproven theory that it's vaccine based. What I think we can glean from this in particular is that we recognize autism spectrum disorders and are labeling them as such, versus I think in the past children went unidentified. And also that I think because schools are more knowledgeable, because of all the work being done on awareness, like Autism Awareness Month, I think we are getting more kids into the proper categories of identification in terms of autism spectrum. Autism spectrum, and just the word itself, spectrum, tells you that there is a lot of different elements to it. It's a wide spectrum. We talk about kids being on the low end or the high end of the spectrum, meaning really, really complicated, maybe really significantly cognitively impaired, all the way up to individuals that are very high intelligence, but are impacted in social skills ways. So, one of the favorite things that people will say is if you've met one person with autism, you've met one person with autism. But there are some generalities, there are some characteristics that we can talk about in terms of the overall autism spectrum. So let's get into that. Actually, what I have for you is a little video right now I'm going to show you that is on the early signs of autism. And what you're going to see is children suspected of having autism, and then children who are not showing signs of autism, and they're going to play out the differences for you. So I'm going to play this video now. Nope, I don't want me. Yeah, that's what I want.
I'm Rebecca Landa, Director of the Center for Autism and Related Disorders at Kennedy Krieger Institute. You are about to watch a brief tutorial illustrating the early signs of autism spectrum disorders, or ASD. You will see 3 pairs of videos of 1-year-olds. Within each pair, you will first see a child with neurotypical development, followed by a child who shows early signs of ASD. The developmental features indicative of ASD shown within these videos fall into 3 main categories. These include effective communication and sharing enjoyment, making social connections, and the one with which we will begin, seeing social opportunity through play. This 19-month-old child does not show signs of ASD. He has chosen to play with the balls. He quickly integrates the lady into his play. He pretends that the balls are food and offers a bite to the lady.
He pretends a lot of stuff is food, and he always wants you to
offers
eat
it to you. Okay. You're making some yummy food.
He understands that food, spoons, plates, and eating go together. As he creates a pretend play activity, he remains aware of the people nearby. He enjoys incorporating social interaction into his play and offers the lady a bite.
Thank you. That sure is tasty.
He is able to pay attention to the lady, the doll, and the pretend food all at once. He shares his excitement about the toys with the lady, looking at her and smiling. After the lady comments that the food is hot, he links his play and language to her idea.
It's okay now. It's cool. It's nice and cool then. Yeah.
Here, he imitates the lady's action with the pretend lipstick.
My lipstick pretty now. My lipstick on. Oh, it doesn't come off.
This helps him to learn new play skills and at the same time synchronize his actions with the actions of others.
Yeah, she has lipstick on. Oh, just like Mommy wears. You look so pretty. Thank you.
This 19-month-old child shows signs of ASD. He has an intense interest in the toy phone. He does not share his enjoyment of the phone with others. He does not look toward others and smile.
Shows, sensory, all kinds. He really has this addiction to telephones lately, though. It's okay, though, because it's helping him to make sounds, so there's probably like 10 telephones laying around my house, because he walks around carrying them and sits them down, and then he goes on to the next one.
Although he puts the phone to his ear, he does not show creative play with the phone. When his name is called, he does not respond.
Elliot. Ellie. Ellie. Elliot.
He does not offer the phone to others so that they can have a turn.
He returns to his name, and progressively he's not.
His mother tries to distract his attention away from the phone.
Let mommy see the phone. Let mommy see it. Let mommy see the phone.
There you are.
She begins to tickle him. Although he seems to enjoy the tickling, he does not look at his mother or make a social connection with her. He does not try to communicate with his mom to keep the social game going. This 14-month-old child has a mild motor delay but does not show signs of ASD. As he explores the new toy, he remains aware of the people nearby. He checks in with his mother behind him to ensure that she also sees the toy. Next, he shows that he understands the social communicative meaning of the woman's pointing gesture by immediately looking at the sticker. Then he looks over at another sticker she had pointed out before. He continues the woman's topic of communication as he points to the Tigger sticker. He shows the motivation to maintain social engagement with others and the ability to communicate using coordinated gaze, vocalization, and gesture. This 14-month-old shows signs of ASD. First, he flaps his hands while enjoying the bubbles. He does not share his enjoyment by looking at the man. He does not respond to his name.
Ben. Ben. Ben.
Although he looks at the man's pointed finger, he does not follow the direction of the man's gesture to locate the object of the man's attention. This 14-month-old does not show signs of ASD. While she enjoys looking at and exploring the toy, she stays engaged with the people nearby. She tries to share her enjoyment with her mother as she turns to show the toy to her. Then she shares her enjoyment with the lady across from her by directing her gaze and smile toward the lady. Also, she recognizes that the lady is a source of help. Her request for help is clear and effective. Coordinating eye contact, gesture, and vocalization for purposeful communication is a sign of healthy social and communication development. This 14-month-old child shows signs of ASD. Notice how his attention is so focused on the toy that he does not interact with the people nearby. He does not share his attention with others. His exploration of the toy is also unusual. He drops the toy onto the table and watches it move. When the toy stops moving, he does not use eye contact, vocalization, or gesture to ask for help. He also tenses his body and mouth in an unusual way.
Do it again?
Even though the lady is talking to him, he shows no interest in her. He does not seem to understand that her gesture is an offer to help him. He does not check in with the lady or his mother to see whether they are paying attention to the toy that he is enjoying. ASD is a neurodevelopmental disorder affecting multiple aspects of development, especially social and communication skills. Children with ASD often show unusually intense interest in certain objects or sensory experiences. They may repeat certain behaviors over and over again. The signs of ASD are not transient, but rather persist over time. The earliest signs of ASD are often subtle and become clearer in the second and third year of life. A diagnosis of ASD should be made by one or more experts who gather a thorough developmental history, directly assess the child's developmental abilities, and conduct a medical exam. For more information about ASD early detection and intervention, or to sign up to receive our newsletter, please visit autism.kennedykrieger.org/card.
Okay, I really, really like that video because of the difference that it shows you between the children who are not suspected of being on the autism spectrum and then the children that are. And in young children, finding those differences is subtle. But when you hear the narrator taking you through it, it becomes almost painfully obvious where some of those communication and social skills deficits are as the children are not, following that natural inclination to get someone else involved, get someone else interested, share their enjoyment, connecting with other people, and then that kind of just that, like the little guy with the phones, just listening to the parent talk about that he's got phones all over the house, and so quite pervasive in their desire to be around things that they're interested in and are motivational to them. So, you can kind of age up these kids too and see how these deficits would also then start to impact them in the school setting, because if you are not a good communicator, if you're not catching social skills, if you're not relating to other people, you're missing big chunks of information, whether it's in a social setting or a learning setting. Okay, so one of the things that has recently occurred with autism is that there is one main tool that professionals in the field of education and medicine, psychology, counseling use to identify individuals by a consistent set of criteria, and it's called the Diagnostic and Statistical Manual, or the DSM-5. And every so often, there is a new version of this manual that comes out. Excuse me, I gotta get a drink of water. By the way, I'm sorry if I'm sniffing and coughing and you're hearing it. I do apologize. I'm still trying to get through this cold. So in this manual, they do revise it every few years, and it's a very lengthy process because it's literally the Bible in terms of identifying individuals under specific disabilities, and there's all these categories and codes and whatnot. And basically what they did a few years ago when they did the DSM-5, the latest version, is that they took various kind of wings of autism. You hear people talk about Asperger's, having a pervasive developmental disorder, and then just autism in general. And they took all those and they put them under one umbrella, basically saying there is one diagnosis, and it is the autism spectrum disorder. So professionals who are now identifying individuals who have these kind of deficits are to use the one criteria of autism spectrum disorder. And that is important to you because you'll hear people talk about terminology that's now considered a little bit outdated, like Asperger's or PDD, pervasive developmental disorders. And they're not necessarily wrong, but as you're going into the field as new professionals, you want to be working with the most current information. And so right now, we just identify individuals being on the autism spectrum. And in the school setting, we would not tease out something like Asperger's or pervasive developmental disorders, even though there are a fair number of tools that are designed just for those kind of little pieces of the autism spectrum. So as I said before, that terminology of Asperger's syndrome and then just autism by itself aren't separate anymore. They've been absorbed. But we still know that there's elements of these different disorders, even though they're under one umbrella now, that we can talk about a little bit. In terms of Asperger's, the main characteristic that we talk about in terms of Asperger's is that it's an impairment in social interactions and that rigidity, resistance to change, that narrow focus of interest. If you watch The Big Bang Theory and Sheldon, that is Sheldon. I don't know that the developers of that TV show were thinking about autism awareness or thinking about someone being on the autism spectrum. I think they were looking for a caricature of someone who is, very deep into their knowledge and it impacts them in all areas of their life, and it's interesting to watch how that plays out. But every time I watch the show, I'm spending all my time thinking about how he's on the spectrum, because that's kind of who he is. And there's a lot of individuals that are very successful individuals out in the workforce who have many of those characteristics. And you can see how, even though Sheldon is a fictional character, it serves them very well because they become extremely skilled in the areas that are of high interest to them, and they dive deep and heavy duty into those topic areas and become experts. Of course, the problem is sometimes in the translation of being able to take those skills and use them in the workplace setting, when you not only need to know your stuff, you have to be able to communicate it. So, all right. Going on into the DSM-5 a little bit more, now that they have pulled all these different disorders under one umbrella, we can talk about that they have to see these kind of characteristics to be considered within the autism spectrum. So, as defined, the first one is that persistent deficits in social communication and social interaction. That one we know, and we saw it a little bit in that video from the Kennedy Krieger Institute. Restricted, repetitive patterns of behavior. The little guy talking about the telephones and the mom saying he's got telephones everywhere. You know, that's not unusual. I have worked with kids who have been obsessed about dinosaurs, very restricted, wanted to just, every time they visited with you, somehow they managed to make the conversation come back to dinosaurs. Children that were very repetitive in terms of trains. I had a young man who was a middle schooler, and he knew every train schedule. He knew every kind of train. He knew the routes they took. He knew what they carried. And then I had another student who was very repetitive around the weather and loved to have weather maps and know what the weather was and watch the Weather Channel, and that was his focus. And so these kids were experts. No stretch of the imagination to say they were experts in these areas, but it impacted them in other areas because they couldn't necessarily translate that interest into things they could communicate easily, or that allowed them to share that enjoyment with others. They wanted to always bring someone in and say, you know, I know you like sports, but I'm going to talk about the weather. And they'd always find a way to bring it back around. Autism spectrum disorders, we know that they don't just suddenly happen. They emerge as more demands are placed on the child as they grow and develop. We don't expect much out of an infant as compared to a 1.5-year-old who's starting to toddle around and you know, picks up things and offers things and has their own little mind about what they want to do. Again, as we make more and more demands on them, and those social demands, then things start to emerge. Especially, and I've seen this a lot in the school settings, is you will have kids who have lots of intellectual abilities, and they can do school. But as the demands of interacting with peers become more apparent, like by the time you hit kindergarten, kids start to have friendships and tiffs, and I'm upset with so-and-so, and this person won't play with me, and that kind of thing. And oftentimes, a kid who's been functioning okay, maybe appearing a little different, but not to the point that it's got the parents' radar up. But sometimes by the time they hit kindergarten, those demands suddenly just sort of, they run smack into the wall, and then that kid's really struggling. And so we see that quite a bit. Often, you know, that we've already talked about that significant impairment in social, but also occupational, you know, the workforce, other areas of functioning, adaptive behavior skills, knowing, you know, what's safe behavior, sometimes very impulsive, eloping, running away. Sometimes, you know, I kind of talked a lot about my daughter. You know, she has some challenges in accepting no and knowing, you know, when someone's telling her something that's it's good, safe advice for her, but it feels very restrictive. You know, that can be complicating for her. And then finally, if you're going to identify someone on the autism spectrum, it's not better explained by an intellectual disability or some other developmental delay. That's not to say that individuals with the autism spectrum can't have an intellectual disability, but if you're going to identify this as the main disorder, it's not going to be better explained by an intellectual disability. Okay. All right. Another, you know, kind of, we've talked about some sort of wings of autism. Nonverbal learning disorders is an area that doesn't appear in IDEA, and it isn't part of the autism spectrum categories, but it is recognized in the field of neuropsychology. And I know there are individuals in schools everywhere who could be identified as having a nonverbal learning disorder. Basically, these are individuals who function really well in academic areas, but they fall down in that social or communication area. But there's also this kind of other thing happening at the same time, which is these weaker motor skills and visual spatial skills. So these individuals are going to be probably highly verbal, but clumsy, very awkward. They would no sooner pick up a baseball than if you told them to drive to the moon. They struggle with interpreting social skills. What's going on in your face that shows me that you're upset with me or that I said something that was off-putting. So these individuals, while they may not need a lot of direct instruction in academics because they have perfectly adequate skills in that area, they need that social skills direct instruction, all the nonverbals. Remember how we talked about, language and communication starts with listening and speaking and then reading and writing. Well, a good part of listening is nonverbal. As you look at someone and you see what's happening with their body and how they're acting and what their voice sounds like and what their face is doing, and all of those things combine to give you the appropriate communication message. And so if you're missing those things, then again, your learning is going to be impacted. And again, I just want to encourage you to, while we have criteria, we have categories, people are people, and they may or may not fall perfectly and neatly into one area or another. And when you get into the real world, we need to be open to the idea that, yes, they might be on the spectrum, or it might be a nonverbal learning disorder. This does not mean that they don't have needs, because we can't perfectly identify them. And that's always something that I want people to remember, that, criteria is, it's useful guides, but at the same time, in the school setting, you will have kids that won't meet that criteria, and you will still need to figure out how to help them. And it might not always be in special education, but either way, they still have needs. So, all right, so moving away from the autism spectrum disorder, I'd like to spend a little time on ADHD. I think everybody hears the acronym all the time and doesn't think about what the words stand for. Attention deficit hyperactivity disorder is what ADHD is. So attention deficit meaning they lack the ability to maintain attention. Either they're hyperattentive or they're very inattentive. And then the hyperactivity is the amount of motor activity and impulsivity that they have. So you can see the definition that's right here. ADHD, a persistent pattern, meaning just a one-time burst of inattention or hyperactivity doesn't mean you have ADHD. So a persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning or development. And that's very important because we have when we talk about, remember we've talked about developmental theory, and as kids grow, your attention levels become better. So we probably would not consider a little person who's jumping from place to place and doing things to things as being someone who has attention deficit, because of the developmental theory that we know that they just really aren't at a point in their development where they can attend for those longer periods of time, and it's natural for them to be jumping up with bursts of energy and running off and doing something different. And so we apply that again in coordination with the developmental theory. So again, when you're seeking to identify someone as potentially having ADHD, you're going to look for that persistent pattern, and then that it interferes with their functioning or development. And you can well imagine in the classroom setting when you have attention issues that are persistent, meaning they're continually impacting you, how that would affect you in a classroom if you're struggling to attend to the instruction that the teacher is providing. The other thing is we can talk about attention deficit disorder without hyperactivity because not everyone has the hyperactivity impulsivity component. A lot of kids, though, do have both. Okay. All right, so I have another video for you. And this particular video it's from BuzzFeed, I know, but it still is worth watching because it's young adults talking about their own experiences in having attention deficit.
I think with ADHD, the problem is that you sort of, I'm going to try to rephrase this because I'm sort of going on a tangent.
What just happened?
What was I saying? I misbehaved a lot as a kid, but I didn't mean to.
The natural environment of a classroom is very non-conducive to somebody with ADHD. You know, just like this quiet room, you're sitting at this table, a bunch of other kids are all doing their work. It was almost like it's sensory overload. Like everything is coming at you all at once.
I would be trying to focus on this teacher, and then all of a sudden I would like snap to it again, and I had missed half of what the teacher had talked about. I was like, "You're high" or something. It's kind of similar to being high.
One of the side effects of ADHD is a sort of an inability, or at least a tough time staying still, concentrating, focusing on day-to-day tasks.
I feel like my thoughts are sort of on like a carousel in my brain, and it's going in circles, and each thought stops for like 2 seconds in front of my eyes. I can barely grasp it, and then it's gone.
The third day I was at BuzzFeed, I was taking some like safety test with my friend, fellow producer here, Caitlin, and I'm like already lost on like the packet. I look over and like Caitlin's answered like the first 10 questions already. And it's just, that's like a story of my life, is like looking over to my friend and being like, how the hell did you just do that?
I have been on some form of medication ever since I was 13.
I stopped taking medication for me because I just didn't like the way it made me feel. They curbed my appetite, I was losing weight.
But the medication provides me with clarity.
When I'm not on my medicine, it feels like the smallest tasks are really overwhelming because I can't visualize and focus on the simple process.
I have to plan things out. I have to write everything down or else I forget. I don't advocate that everyone go off their meds. They don't need to. For me, that was something that I felt I wanted to do.
It looks different in everybody. I would just wish people were a little more sensitive with like the verbal assumptions they make.
I just wish people believed it was real. My ADHD is like the realest thing in my life. Like I can't reach out and touch it, but I can feel it.
Okay, so I do like that video because I think it tells just a quick snapshot story of what it was like for those young adults who had this problem growing up through school, and now as they're starting to get into the workplace, you know, how it affects them. And you can hear them talk because, you know, a couple of them are like, I really need the support of the medication that I take to help regulate my ability to function. And others are like, nope, I decided I didn't like how it made me feel, and so I chose not to do that. And that is a very personal choice. And especially in the school settings, we have limitations that are actually built into the law of IDEA that says, you know, you can't require parents to take their child and get medication. You know, you need to let that be the choice of the family. You know, it's not like, you know, I would say to a family, well, you know, I think you need to take your child and go, you know, enroll them in soccer. You know, that's none of my business. That's your decision. And medication is kind of the same way. Although I will say that when families are dealing with a student or their child that they know has this now identified disorder of attention deficit, they will ask, you know, and sometimes they just want the opinion of someone else. You know, what do you think? You know, it's kind of like when we watched the, if you remember, starting, you know, this semester with the Learning Disability Unit, and everybody watched the Misunderstood Minds video, and the family struggling about, you know, do we do some sort of medication to try to help our child? And it's the same conversation. Families want to, nobody wants to put their child on medicine, especially when they're 8, 9, 10. You know, but they will often ask teachers, administrators for advice. And that puts you in kind of a difficult position, but you're also, that's a trust situation to share, well, this is your choice, but here's what I can tell you what I know. And often what I could share was, I've seen for some kids that it was a really good tool that made learning better for them. And I feel like, it's sometimes is worth giving it an adequate trial to see if it's something that you're comfortable with and works. But everybody makes their own decisions. And again, in a school setting, we have to be very careful about appearing like somehow we're forcing or coercing families to choose a course of treatment that they certainly have the ability to say yes or no to. So it's kind of a little bit of a dance. There's the criteria for from the DSM-5. Remember, that's the kind of the Bible for how we identify kids with disabilities, or anyone. Actually, it's for any person that might have a disability. And in the DSM-5, it talks about the severity, that the symptoms have to be more frequent and more severe. Remember, we talked about that persistent status of inattention and hyperactivity and impulsivity. It should be something that doesn't emerge later in life. It should be something that happens early onset, that we're seeing the symptoms before age 12. And then it has been going on for a while. Again, we had that persistent language earlier in another slide. And the DSM-5 says it has to have lasted for at least 6 months. All right, and here is a couple of subtypes of ADHD in the DSM-5. One is inattention, and that is hyperactivity and impulsivity. That's meaning that as part of having ADHD, you are primarily hyperactive or impulsive. And then there's also kind of an other unspecified or other specified or unspecified ADHD. Remember how I talked about like nonverbal learning disabilities and Asperger's, and there's all these little different components. And this one in the DSM-5 is actually recognized, and it says you're not meeting the full criteria, but you do have the kind of symptoms that do cause clinical distress or impairment. Now, why do we have this kind of a modifier? Well, because we have insurance companies, and they want to know that if we're treating someone for something, whether it's through therapy, counseling, medication, they want to know that a medical professional has established that there's some criteria for what's going on with this individual. And so someone may have other specified ADHD or unspecified because they're getting some sort of a treatment, counseling, medication. All right. And again, also in school settings, I think it's worth noting that not every kid will fit perfectly in every set of criteria you have. That doesn't mean they don't need something. So, characteristics of ADHD. As we move across the developmental stages in the young children, we're going to see that really excessive gross motor. Every little person is active, at least if they're healthy and able to, they should be active. But you will see kids who are abnormally out of the norm doing gross motor activity. They're the Energizer Bunny that never stops until they just drop. Elementary age, what do we expect in elementary? Kids are supposed to be able to sit at desks, at tables for longer periods of time. You will have kids that just really cannot do that. It really is they're fidgety, they're moving, they need to move, they have that extreme irritation, restlessness. They just need to feed, their bodies need to move. And it's a real feeling. As adolescents, it can transition into characteristics of having low self-esteem and behavior problems. And if you remember from the video, one young lady said, I was bad when I was younger, and I have strong opinions about people being bad. I think mostly it's you're reacting to your environment. There's something developmentally happening with you that is the way your behavior is just showing your reactions to your life. And if kids have had a tough time in school, and they have to come to school every day because it's their job, and it's hard for them, over time it's gonna turn into that low self-esteem, the stuff we were just talking about on Monday. Kids really can find themselves in a place where school is not motivating to them. It's not a place they want to come to because they haven't had success. And then finally, as you move into young adults and adults, it can turn into job problems and relationship problems. If you have a partner who never remembers to put the trash out, or leaves their dishes everywhere because they can't remember to put them in the dishwasher, and on the job, if you forget details, you get scattered, or you have other problems, it can turn into losing a job, or not getting promotions, or failure in the workplace. And all of those things are impactful. And so, the one person, again, I kind of go back to that video, the one young lady said, I wish people realized it was real. And I think that's a fair statement, that if you have not experienced this particular disorder, I think it's easy to say, you can take control of this. Just pull yourself together, make lists, and write things down, and you'll be fine. No, they need to be supported with specialized instruction, with compensatory skills, with remediation, so that they know, these are the ways I can best tackle the learning challenges that my brain gives me. So when we go to assess autism, when we go to assess attention deficit challenges, we typically use rating scales. We've talked a little bit about rating scales in terms of adaptive behavior, when we're measuring things like independent living skills and how someone is able to dress themselves and cook and get around their community. Those we use rating scales for. We kind of have we have a rating scale method for identifying individuals who have attention deficits and hyperactivity disorders. And basically, you get multiple people to complete these scales so that you can see trends across multiple people. Obviously, if we're doing it on a student, it's going to be done by the teacher of the student, the parent of the student, and then probably the student themselves if they're old enough. And what we're looking for is that consistency, that this is a problem in this setting and people see it. So we always say, when you're going to use a rating scale for assessment, whether it's adaptive behavior, there's rating scales in autism, in assessing for ADHD, of course, there's these behavior rating scales. You want to have multiple people doing it because that enhances the validity of your results. If you just take the teacher's viewpoint and not maybe the parent's viewpoint, you're probably not going to get a complete picture of the student. Some examples of behavior rating scales that we would use in assessment of ADHD include the Behavior Assessment System for Children, which often is just called the BASC, and then the Conners Rating Scale. Excuse me. All right. Somehow I just added a slide. That's exciting. Here, we'll go here. Keep in mind that not every student who has attention deficit disorder is going to be eligible for special education. And then, just like we know students who have learning disabilities can be eligible, can have students with learning disabilities can be gifted. Students who have ADHD can also be gifted. That kind of raises the question, I've talked about this a lot in this particular lecture, is that you will have those kids that don't meet the criteria. And with those kids that don't meet the criteria for special education, they may need some accommodations. And we talk about accommodations under Section 504 of the Rehabilitation Act. Here's some prevalence statistics on ADHD. Again, you can see the rise. It's starting to level out just a little bit here. But basically, it's fairly consistent. Approximately 9.4% of children between the ages of 2 and 17 have ever been diagnosed, according to Parent Report. So it is not uncommon. It often occurs with other disorders. That's why we say it's comorbid. A lot of children who have ADHD have other challenges happening at the same time. Obviously, learning disabilities is one. They may also have behavior or conduct problems, may have anxiety, they may have autism, depression, Tourette's. My own daughter on the autism spectrum also was diagnosed with an attention disorder and does take some medication to help support her attending. She is very much impulsive, and then she has a lot of challenges in just attending. So not unusual at all. Placements for children who have attention deficit disorder. When we identify them in special education, because attention deficit disorder is a medical disorder, they're identified under the category of other health impaired. And so when we look at the category of other health impaired, which can include more than just individuals with attention deficit, it can be individuals with seizure disorders, they've been going through cancer treatments, they have other metabolic disorders, lots of other disorders can be under this category, but I would say the majority of individuals under other health impairment are those with attention deficit disorder. So as we look, we can see the majority of these students are served in the regular classroom. And that makes some sense because we know that typically there's not a major impact in terms of ability levels. It's more about the brain's ability to attend and you know, dealing with the urges for hyperactivity. Some treatments, and we've kind of talked about those as we've gone through this particular lecture. Medications can reduce some of the symptoms. Often the first treatments that are done for ADHD are to give children medications that they're stimulants in nature, but they actually work in the opposite effect for individuals with attention deficit, which is kind of interesting. It can improve their focus, and I have seen some really amazing results from children that have received some support through medication. Therapy can be effective in helping just deal with the symptoms. You know, why am I like this? Why is this hard for me? And you know, going into counseling and supports that way. And then finally, just overall training and learning about what it means to have attention deficit disorder, I think can promote self-esteem and prevent things like depression and other behaviors from possibly emerging if you understand why your learning is challenging for you. Okay, finally, some strategies. I'm going to move myself. I'll get over here. There we go. These are some things that are suggested as tools to help students dealing with their own behaviors, and then also instructional strategies. And some of these you will remember because we've just been talking about them. Obviously, behaviorally, if you're a student that's challenged in remembering to take your papers home, get them done, bring them back, maybe we develop some skills in terms of keeping track of your homework, using planners, making contracts, getting high levels of commitment to I'm going to work on this area. Self-monitoring tools, we've talked about the value of that when students see their own progress, it's really helping influence their own feelings of success, and success breeds success. Token economies, you've all experienced some sort of token economy somewhere in your school setting where, you know, somebody says, if you do this, you get this, and, you know, kids will work for things that are motivational to them. Always remembering that you have to match what you're offering as the carrot to whatever skill that you're trying to increase. So if you want the student to bring their work home, get it done, and bring it back, and so you're going to, you know, give them a sticker every time they do that, you better be sure that stickers are something they want to work for. Because if they don't care about stickers, they're not going to do it. And then on the other side, instructional strategies. These are all things we've talked about. We have talked about peer tutoring. Sometimes the value of working with a peer in the ways they can help students cut through the instruction that they weren't following from the teacher. And that peer not only helps them with good, balanced information that is in the language that makes sense to them, but also starting to develop some of those peer relationships that can be impacted by the disorder. We've seen some examples of graphic organizers. Those are great ways to get visual representation of skills you're learning, concepts you're learning. Mnemonics we've talked about, you know, every good boy does fine, PEMDAS. Giving breaks. If you're someone who is struggling with attention deficit hyperactivity disorder, your body needs to move. You know, we chunk our information. Again, good technique for anybody, works for individuals with attention deficit. And then just that flexible seating, and that's something we talked about yesterday as well, or yeah, it was yesterday. You know, allowing kids to move, to stand, to kneel, you know, place them in the room that works best for them. You know, maybe they need to be away from the door because every time somebody walks by, they're looking. Maybe they need to be away from the window because they spend all their time looking outside when birds flutter by. You know, what can we do to make the room work for them? Okay, so that's the majority of our lecture. What I would like you to be able to take away, remembering that prevalence rate of autism, knowing that it was just revisited by the Center for Disease Control, and we can go way back to that slide. It's way back up here. 1 in 59. That's pretty stunning. And then also, what are some ways that we can work to treat the symptoms of ADHD? And so we talked about those. Medications, therapies, and education and training are all different ways you can support individuals who have attention deficit. Okay, so now that you're done with this lecture, you're going to go to the forum and you're going to post your response to the question that I have provided. This counts towards attendance. I will check. Please go post. Friday, your practicum papers are due. Monday, we're going to have the quiz. It's going to cover co-teaching, collaboration, learning theory, instructional practices, related disabilities, and the Conrad article. So everything up until right now, since the last quiz, is what your next quiz will be on. Okay? So that's all I have for you. Thanks, everybody. Have a great day.